Clb+O study examined whether a fixed duration venetoclax and ibrutinib was superior to chlorambucil and obinutuzumab, a standard chemoimmunotherapy regimen for less fit elderly patients with CLL. And the background and the rationale for the study is that we have two very powerful drugs in CLL. We have ibrutinib, which is very effective in chasing cells out of their lymph node microenvironment. And within this lymph node microenvironment, they obtain signals from other cells, which make them not only into a proliferative state, but also make them into an apoptotic resistant state. And we have venetoclax, which is a very specific BCL2 inhibitor, which very effectively kills cells in the blood. But because of this protective microenvironment, those cells are less vulnerable, less sensitive for venetoclax in the lymph node compartment. So if you combine these two drugs, in theory at least, then you actually have the best of two worlds. You chase cells out of this protective microenvironment, sensitizing them for the killing effect of venetoclax. So that was the rationale of the study. And the idea is that if you combine such very effective agents, you might be able to stop treatment instead of continuous treatment until relapse. So that was tested in this trial. So in this trial, we gave a lead-in of ibrutinib for 3 months, which also effectively debulked patients, also lowering the risk of tumor lysis problems because of the venetoclax. And then for 12 cycles, venetoclax was combined with ibrutinib, and then treatment was stopped. So this is a phase 3 global head-to-head comparison of the ibrutinib venetoclax combination, 3 months of ibrutinib lead-in, and then 12 cycles of combination with venetoclax, where the first cycle venetoclax was given as a ramp-up dose. And this was compared with a 6 cycle of chlorambucil obinutuzumab, which is the labeled duration of treatment. So what we reported at EHA already a few months ago was that the progression-free survival was very significantly better in the study arm than in the standard arm, with a hazard ratio of 0.2, so very powerful. And what we show at this ASH is we focus very much on MRD, and minimal residual disease is more and more used now as a surrogate endpoint for depth of remission in CLL and as a surrogate endpoint for progression-free survival. The threshold is usually set at 10 to the minus 4, meaning if you have less than 1 leukemia cells in 10,000 normal cells, you have an undetectable MRD, and if you're above that, you are positive MRD. And we know from other trials with chemoimmunotherapy and with venetoclax plus an antibody, that patient with a positive MRD usually do very poorly after stopping treatments. So we had three, I think, key messages in this trial. The first key message is that there was a significantly higher proportion of patients which got into this undetectable MRD state with the ibrutinib venetoclax treatments, both measured in blood and in marrow. Second take-home message is that not only more patients came into an undetectable MRD state, but with next-generation sequencing, we could actually measure what happened below 10 to the minus 4, and we found that significantly more patients had deeper undetectable MRD levels, 10 to the minus 5, which is like 1 log deeper. And the third take-home message is that after stopping treatment, their MRD levels, regardless if it was negative or positive or intermediate, they were much more sustainable. What I mean by that is that in the standard treatment, patient with a positive MRD almost always went up at least a log up or even go into a progressive state after stopping of treatments. And in this study, we saw that MRD rates were much more sustainable. So even if you had a intermediate level of MRD, most of those patients remained at that very same level 12 months after stopping of treatments. Yeah, so now it gets very interesting because now we have a few different options for patients with CLL. Of course, we still have, and it's a big debate which patients should that be, but you still have chemoimmunotherapy, which you can give to patients. You have BTK inhibitor treatment as a maintenance treatment, so you continue until relapse. And now you also have two very effective prospective combined targeted agents that you can give for a fixed duration. One is venetoclax ibrutinib, which is an oral once daily regimen that we discussed in the CLO study. And the other is the venetoclax obinutuzumab setup, where you give 12 months of combination of venetoclax and first 6 months combine it with obinutuzumab, which is an antibody that has to, of course, be given intravenously. Which treatment you should give for which patient, that's still an open question. And currently in Europe, we are very fastly actually enrolling the CLL17 trial led by Othman Al-Sawaf from Germany, where we actually head-to-head compare ibrutinib venetoclax, one arm, venetoclax and obinutuzumab, second arm, and ibrutinib maintenance as a third arm. And I think that's kind of studies will help to determine which patients will best do in what setup.